This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. This morning we have one of our own with us. Dr. Modele Ogunniyi is with us today. She is an associate professor in the Division of Cardiology. She joined the faculty in 2009. Good guess, wasn't it? And she did her medical training in Nigeria, came to the U.S. and had completed a master's of public health at Johns Hopkins, did a fellowship at CDC, did her internal medicine training at Morehouse, and her cardiology fellowship at Vanderbilt. And we were fortunate to recruit her here in 2009. She is very active locally, internally, and externally in various professional organizations. Gave a rousing medical grand rounds last week on mentoring. And today she's going to talk to us about probably the most untreated disease in cardiovascular medicine, hypertension, and about healthcare equity issues. Modele, welcome.
Thank you, Bob, for that introduction. Good morning, everybody. Today, I'll be talking about disparities in hypertension, charting a path towards equitable cardiovascular outcomes. My disclosures are not relevant to this topic. So I hope that over the next 45 minutes or so, I want you to think about the patient who presents before you in clinic with uncontrolled hypertension. And I hope that at the end of this talk, you will think about how to manage this patient in a different way, or should I say from the public health perspective. So today I'm going to talk about the impact of social determinants of health, share with you multi-level factors that influence disparities in hypertension control, and I hope you will take away practical strategies to improve blood pressure control. I'll highlight some multidisciplinary based care models as well as clinical community engagement, which has been shown to decrease disparities in blood pressure control. So I think this talk is well suited for this month. This month is National High Blood Pressure Education Month. A lot of focus on high blood pressure, stroke, and reducing the morbidity and mortality. And one thing to take away is that we all have to make high blood pressure a national priority, as you'll see in subsequent slides. It's no surprise to this group that hypertension is the leading cause of cardiovascular morbidity and mortality, not only in the US, but globally. And when we look at cases of hypertension, defined as the prevalence of hypertension, that is a systolic blood pressure of 130 over, greater or equal to 130 over 80, the prevalence is approximately about 45%. We all know that the racial and ethnic disparities in hypertension are well documented. In fact, Black adults have one of the highest hypertension rates globally. National hypertension control remains a persistent public health crisis. In fact, recent published data show suboptimal hypertension control rates, particularly for minoritized population groups. So let's talk some epidemiology. This is NHANES data, the National Health and Nutrition Examination Survey conducted annually by the NCHS. It looks at trends in different risk factors, and this is the one for hypertension. This is the latest data we have. So it shows age-adjusted prevalence trends for hypertension for US adults by age, race, and ethnicity, and sex. And when you look at the distribution by race, what pops out to you is that Black males and Black females have the highest prevalence of hypertension. So these disparities exist across racial and ethnic groups. This is the same data. This is presenting the latest data we have in the recent heart disease and stroke statistics. So about males have a higher prevalence of hypertension compared to females. Over 120 million US adults have hypertension, or what we call high blood pressure. But when you stratify by sex, you see that black males almost approach 60%, and black females are equally approaching 60%. When we talk about disparities, it's not only disparities by race and ethnicity. Disparities exist across gender, sex or gender. Disparities across geography, so where you live, or people say your zip code can determine what kind of cardiovascular outcome you have. That's one of my interests, is looking at rural versus urban disparities in cardiovascular disease. As you can see from this CDC conducted survey, the behavioral risk factor surveillance system, they define and really show us the stroke belt. So the southeastern part of the United States, where you have a preponderance of risk factors, be it hypertension, stroke, obesity, those maps overlap. And that shows us there's a lot of work to be done. So switching gears, we've talked about the prevalence of hypertension. Let's look at the extent of awareness. So in NHANES, and also reported in the recent heart disease and stroke statistics report put out annually by the American Heart Association, they always talk about awareness, treatment, and control. So the awareness is represented in the blue bars. So when you look at awareness, we're doing a good job, maybe not as much. People are aware that high blood pressure, the average person may be aware that high blood pressure is a silent killer. And as a nation, we've done a lot of work with public health campaigns on high blood pressure. Particularly look at the black females. There's a lot of programs out there targeting black females, because in the past, they seem to not be aware that they have high blood pressure. Moving on to the red bars, we look at treatment. We're still not doing a good job with treatment. We have clinical trials that have gone on. We have new treatment modalities. We have lots of medications. In fact, the medications to treat hypertension are really affordable. So why aren't we doing a good job with treating high blood pressure? But where I spend most of my time as the co-chair of the National Hypertension Control Roundtable is in the area of control. What pops out to me here is, if you look at the male subpopulation, right? So if you look at Hispanic males, they have the lowest control of hypertension, followed by the non-Hispanic Asian male and the black male. Even as a whole, the national control hypertension rates, as you will see, is less than, is about a quarter. So going back to, this was my first publication in 2003 as a preventive medicine fellow at the CDC, and I had the opportunity to update it in 2021. But as I went back to review both papers, nothing has really changed. In this paper, I reported that 25% of the population have their blood pressure controlled based on the NHANES data that was available at that time. And guess what? In this new paper, 1 in 5 Americans, that is 20%, have their blood pressure controlled. So whether we talk about a blood pressure goal of 140/90, which is the blood pressure threshold that is used in Europe, or we come to the US where a blood pressure control is less than 130/80, we are doing a bad job of controlling hypertension. About 1 in 5 adults in the US have their blood pressures controlled. So that's where I'll be focusing most of my talk. So why are blood pressure control rates very poor? Multifactorial. It has to do with the environment, the health system, patients, and in this lower bar where we find ourselves. Particularly compelling is clinical inertia. I mean, I recall many times when I'm staffing patients in the clinic and a fellow presents a patient and blood pressure is like 150/90, and I ask them, so what are you going to do about the blood pressure? Then the excuses start. Oh, this patient came late, they couldn't find parking, they spent time sitting in the waiting room, they've been waiting for me for 45 minutes, oh, they had a cup of coffee, and the excuses go on, and we miss that opportunity to make a difference by adjusting their blood pressure medications. Of course, that's not all the blame. As clinicians, we have competing priorities. Patients come, they have different things, especially at Grady, where their blood pressure is uncontrolled, they're in heart failure. They have we have different competing priorities. How are we measuring blood pressure? What's the technical skills of our support staff? Another issue of equity is the issue of cultural competence. How sensitive are we to culture, to language? What time do we take to make sure that a patient whose English is not their first language, do we take the time to find an interpreter? How many times do people depend on relatives just to save time? So I think that although I focused on this group, I want you to take away that the reason why national blood pressure control rates are so poor is multifactorial. So I talked about differences by sex. This is one area of interest that I have as well. And we have a separate section in our paper where we talk about hypertension disparities in women. There are disparities in awareness, treatment, and control. And there's a special focus on hypertensive disorders of pregnancy. So you remember that I showed you that among Black females, they really have the highest prevalence, approaching 70%, of being aware of hypertension. But when you look at the trends from 1999 to 2008, which is the latest data that we have, we find large increases in awareness but for Black female, they have remained stagnant. And when we think about hypertensive disorders of pregnancy, which include chronic hypertension, preeclampsia, eclampsia, when you look at the trends over the past 40 years, which is the latest data we have available, it is really an epidemic. There's been an increase of greater than 13-fold in chronic hypertension, that is a hypertension with a systolic blood pressure of greater or equal to 140 or diastolic pressure greater or equal to 90, either before pregnancy or less than 20 weeks of pregnancy, because after that, that's when you diagnose hypertension in pregnancy. But when you even stratify by race and ethnicity, Black women have a persistent twofold higher rate compared with white women over the 40-year period. So in line with this, CDC has different demonstration projects to look at controlling hypertension in priority populations. And we recently received a grant, a demonstration project, to really provide support for women with hypertensive disorders of pregnancy in what we call the fourth trimester, so that vulnerable period after they've had their baby. And the demonstration project is using community health worker support, community health workers who act as coaches, navigators, and also providing support in terms of addressing social determinants of health. So we have partnerships with the Food as Medicine program. We had partnerships with the Y to provide lifestyle medicine with childcare support. And we're just in the initial stages of this project to see how we can impact women who had high blood pressure during their pregnancy. So going back to one of my objectives, social determinants of health, I'm sure we've heard a lot about this, especially concerning the climate of the country. This definition of social determinants of health is the definition that I like the most because it's simple, it's easy to understand. Social determinants of health are conditions in the environment where people are born, where they live, they learn, they work, they play, they worship, and age. But guess what? These social determinants of health affect a wide range of health functioning and quality of life. So what are these social determinants of health? This is a schematic from Healthy People 2030, which is kind of a set of nation plan that is put out every 10 years to see what can we achieve to improve the health of people in the United States. So they include education, but not only access to education, but the quality of education received. Healthcare, access and quality, economic stability, social and community context, and neighborhood and built environment. So talking about the impact of social determinants of health, they do have a tremendous impact on an individual's health, and it doesn't matter their age, their race, or their ethnicity. So when we talk about social determinants of health, this is where you and I as clinicians spend all our time. But guess what? 20% of a person's health or outcomes is related to healthcare, both quality and access to care. The physical environment, the socioeconomic status, the health behaviors are responsible for 80%. So I hope you're still thinking about that, your patient who has uncontrolled hypertension, where we spend most 100% of our time in healthcare. Perhaps we should have a different approach and think about all the social determinants of health that really have an impact on getting their blood pressure controlled. This schematic is put out by the University of Wisconsin Public Health Institute. It rates the health of counties, and it's telling us the same thing. We spend all our time in providing clinical care in an area where it only impacts 20% of outcomes for our patients. So let's talk about social determinants of health and cardiovascular disease. In 2015, the American Heart Association put out this scientific statement calling out social determinants of health, the risk and the outcomes for cardiovascular disease. And it's the first time that the American Heart Association calls out racism. I bear to say that race and ethnicity, as we have known it, we commonly report as risk factors. Race, ethnicity really is not the risk factor. The real risk factor is racism. This is a recent publication put out by Tiffany Powell at the NIH, just emphasizing the same thing, but they put out solutions. What can we do when we look at different social determinants of health and how they impact cardiovascular disease? It's going to take a multidisciplinary partnership looking at policy, community clinical linkages, and really individual interventions. So I'll briefly talk about racism and discrimination and their relationship to hypertension. Interpersonal discrimination and racism are psychosocial stressors that contribute to overall cardiovascular health, including hypertension. Most of the principles I'm going to share today not only apply to hypertension, but all cardiovascular disease and really all chronic disease as we know it. In the MESA study and the Jackson Heart study, examined over, in the Jackson Heart study, they examined close to 2,000 Black adults. And in the MESA study, they looked at close to 3,300 Black adults. And when they looked at them, lifetime discrimination was associated with a higher risk of incident hypertension. So these were adults who were free of hypertension at baseline, and because they were exposed to lifetime discrimination, they developed hypertension. And how did that result? They developed poor coping behaviors. So when you see a patient and you say, oh, this patient's, their diet consists of so and so because it's unhealthy. They do not exercise. Maybe you should stop and think, what is the socio-cultural environment that this patient lives in? And also in that scientific statement, they make a bold statement. They say structural racism is a fundamental driver of health disparities in cardiovascular disease. And these structural factors contribute to poor access to heart-healthy foods, abundance of food deserts, especially in racially segregated neighborhoods. So I hope you're still thinking about that patient with uncontrolled hypertension. So in the 2019 ACC-AHA statement that highlights structural measures for diagnosis and management of hypertension, way back in 2019, they are emphasizing a patient-centered approach. So as we think about that patient, we've got to think about the strategies and make sure that all we're doing is centers around the patient and their support system. And one of the structural measures, really they call it out here, demonstration of infrastructure and personnel that assess and address social determinants of health in patients with high blood pressure. So as patients come to see us in clinic, as we think about adding medications, as we think about enrolling them in clinical trials, referring them for newer treatments, one of the important things in the guidelines is to have infrastructure and personnel in our clinics, in our health systems that assess social determinants of health, not only for high blood pressure, for other cardiovascular disease. So how do we do it? How do we assess social determinants of health? There are a list of screening tools which A good resource website is a website that comes out of UCSF. I'll highlight two of the tools, the Prepare tool, as well as I'll show you how at Grady we're assessing social determinants of health. So the Prepare tool has 16 core measures. It looks at personal characteristics. It addresses the social determinants of health, money, resources. It has optional questions for, has a patient been incarcerated? In this day where we have a lot of immigrants, it looks at refugee status. Is the patient safe? All these are important assessments of social determinants of health. This is a patient I saw recently in my clinic at AC Yancey. In EPIC, which I think that has Emory transitions to EPIC, I hope that this component of social determinants of health is built into their model of EPIC. But in EPIC, we do assess social determinants of health. This is done by the medical assistant, as the medical assistant is triaging the patient, measuring the blood pressure, taking the vital signs. We don't address all the social determinants, but we address major social determinants of health. So I've only expanded food insecurity, which is a main area where Grady has been a leader in addressing social determinants of health. And the MA asks two simple questions. Within the past 12 months, were you worried that food will run out before you get money to buy more? Or within the past 12 months, the food you bought didn't just last and you didn't have money to get more? And if they answer any form of true, that is, they say sometimes true, often true, and they don't have to answer two of these questions, one or two of these questions, they get referred to our Food as Medicine program. These are some of the questions listed that I didn't highlight in the other questionnaire. The food security question is listed here. So patients who identify as being food insecure are referred to the Grady Food as Medicine prescription program. For those of you who have not been to Grady in a long time, the old McDonald's is now a food pharmacy. And I'll share with you some pictures of it. So the Food as Medicine partnership is really an effort by Grady to address food insecurity. And looking at patients who are food insecure, when Grady did a couple of surveys and they found out that 50% of patients who come to Grady, this is not patients with hypertension, are food insecure, amounting to about 140,000 patients. So food insecurity at Grady actually is about 4 times higher than the rest of Atlanta. So the Food as Medicine partnership goal really is to address food insecurity and to drive better outcomes. It's a partnership between the Atlanta Community Food Bank and Grady, as well as a partnership with Open Hand, which is a local resource. So I told you about this is how we address food insecurity, and it has nothing to do really with the physician. Grady initially started out, if a patient has a blood pressure greater than 140/90 or hemoglobin A1C greater than 9, they started out with looking at uncontrolled conditions and answers to one or more questions on the food insecurity question. They are immediately flagged in EPIC as having food insecurity. And this is how EPIC looks. It populates in a red, and as you address all the other social determinants of health, depending on where the patient falls, it could be red, yellow, or green. So this patient happens to be food insecure and has hypertension. So that wheel is populated in EPIC. So it automatically generates what we call a best practice advisory. It highlights in yellow that this patient should be referred to Food as Medicine. And this is what it looks like when you expand the BPA. The MA or nurse opens up the smart set, accepts the smart set, and there's the referral to the food pharmacy, not only to the food pharmacy, but to nutrition services. A patient is handed the flyer, and they even train the medical assistants. They give them talking points to tell them that the patient can take this flyer, or even without the flyer, walk over after their appointment to the food pharmacy and receive fresh produce. So this is how the new food pharmacy looks. For those who remember the old McDonald's, it is really, I had lunch there last week. It is really a sight to behold. I'm inviting you, if you haven't visited Grady in a while, somewhere to visit. So they have a cafe in there as well as a farmer's market that offers free fruits and vegetables to patients, and has employees or affiliated employees, you can get 10% off. So these are actually real pictures. Patients come and they receive classes in EPIC. Some of them were done through Zoom. Not only do they receive life skill education, but they actually have hands-on cooking classes, and they have weekly public demonstrations, and even employees can register. This is a huge freezer. I had the opportunity to go inside, really cold. This is the manager, one of the managers in the food pharmacy who receives the supply from the Atlanta Community Food Bank and prepares bags upon bags for patients who come in daily to receive their supply of fresh fruits and vegetables. So I already talked about this. For now, they're looking at patients with uncontrolled conditions, and recently it used to be in the pods, the primary care clinics, but as of a couple of months ago, it has been expanded into cardiology. So that is one way where Grady as a health system is addressing just one aspect of social determinants of health, which is food insecurity. So shifting gears, because if we want to control hypertension, I believe that as a nation, we have to have set targets. And this is part of what I spend some of my time doing, focusing on and having a think tank on how we can control blood pressure. This is the recent Surgeon General's report that really highlights 3 key roles of how we can achieve blood pressure control. And really achieving blood pressure control is not just so we can improve the overall health. Hypertension control is an equity issue. It's a health equity issue as well as a justice issue. So removing the barriers so that everybody has access to opportunities for treatment, better lifestyles. So it's a national priority. It's important for us to think outside the box, to develop new partnerships, and everything we do, like I've emphasized before, should be centered around the patient. So use standardized treatment approaches, the importance of team-based care, empower our patients, not only empower them, but equip them in the area of blood pressure control. And of course, this will not be complete if we don't put on a health policy hat and think about how can we make it easier. A clinician that has a panel of 30 patients, and out of those 30 patients, all of them have uncontrolled blood pressure, but the clinician has to do with the competing clinical priorities. Maybe this patient is dealing with cancer, has heart failure. How do we recognize, in the way that we incentivize other chronic conditions, how do we really reward clinicians for helping patients achieve blood pressure control? So this slide, although very daunting, shows us that many factors influence hypertension control. With the patient and their family at the center, it has to do with at the individual level, the provider and clinical team, the local community. And of course, we have to think about policy at the level of the national stage, state health policies. We live in a state that hasn't expanded Medicaid. All these things impact the overall cardiovascular health of our patients. So like I mentioned earlier, I was elected to serve as the co-chair of the National Hypertension Control Roundtable. I co-chair along with Eduardo Sanchez, who is Chief Medical Officer for the American Heart Association. And really, this is a coalition of public and private and nonprofit organizations that was assembled in, I think, about 2019 to really think outside the box of how to achieve hypertension control. We know that we cannot achieve national hypertension control without eliminating the disparities. So through dialogue, through partnerships, through scientific evidence, and really innovative mechanisms, we are thinking of how to move from that hypertension control rate where people have 1 in 5 Americans have their blood pressure under control. And the way that we've been doing it is to bring together a couple of both national and local organizations The unique thing about this roundtable is that we're involving employers, we're involving payers, we're involving insurance industries. This steering committee has since grown. We're involving Blue Cross Blue Shield, Aetna, all the people, employers, making sure that employers know that if your employee doesn't have their blood pressure controlled, that putting a dollar amount to it, that impacts productivity, that impacts days spent at work. We have a couple of action teams developing programs and partnerships outside the usual sector to really think about blood pressure control. So just in the couple of minutes I have, things I want to talk about are community clinical linkages, the importance of multidisciplinary healthcare, and to talk about telemedicine and self-measured blood pressure control. So what are community clinical linkages? They are connections between the community and the clinical sector to improve population health. So whatever health system we're in a community, and it's time for us to think outside the box. How do we create partnerships to improve the overall health of the community that we're in? So talking about community clinical linkages, it is important to identify the stakeholders, both in the clinical sector as well as in the community, and kind of creating a focus where everybody can agree on what the goals and the objectives are. To think about sustainability and always have a process whereby you evaluate the effectiveness of whatever you're doing. So we're all familiar with the barbershop trial. It's a very good example of community clinical linkages. The components of the barbershop trial, just to refresh your memory, included a physician-pharmacist collaboration. So there's a collaborative agreement between physicians and pharmacists. The pharmacists had specialized certification in hypertension, and they were the ones really carrying out the intervention. The patients were placed on an effective antihypertensive drug treatment, and care was provided at a trusted site in the barbershop. It's time for us to think about providing care in the community, taking care out of, how many times do we see patients that come into the hospital with white coat hypertension? Perhaps this is a way to think about offering care to our patients in the community where they live. So going over the results of the barbershop trial, you can see that at 6 months, there was a sustained change in when you look at the control group and the interventional group, systolic blood pressure of about 27 millimeters of mercury. I mean, when we think about all the medications, the interventions they were in, to achieve this level of blood pressure control is remarkable. And when you look at 6 months, so this was kind of the initial thing, but when you look at 6 months, whether you look at a blood pressure of less than 140/90 or blood pressure of 130/80, there was sustained blood pressure control even at 6 months. So that leads me to the second point, multidisciplinary based care. And in our paper in JACC last year, we review evidence that has shown that that multidisciplinary team-based care improves blood pressure control. And remember that I said that all these principles I'm sharing with you today really apply to any form of cardiovascular disease, be it heart failure. And at Escape, I'll be sharing how we have used multidisciplinary team-based care to improve the care of our heart failure patients at Grady. So what is really multidisciplinary team-based care? It's a collaborative and coordinated partnership between clinicians, between physicians, APPs, pharmacists, and nurses. But equally important are the allied health professionals on the team, the dietitians, the social workers, the community health workers, because they're really skilled in dealing with the non-pharmacological aspects of blood pressure control. And I think I've emphasized this more than enough, that whatever we do, the patient and their support system must be at the center of all our interventions. So briefly, to highlight the importance of a community health worker. They're non-clinical, they're frontline public health workers. They're culturally sensitive, they're equipped to really deal with patients and help them overcome the barriers to clinical care. They're situated in the community, they're familiar with the stakeholders in the community, they're familiar with processes in the community, And they actually strengthen support for self-management. They help, you can train them on how to train patients. There's a program called Train the Trainer where you train community health workers, and they can go in turn train the patients on how to do SMBP, self-monitored blood pressure. They can serve as coaches, they can serve as navigators, helping patients to navigate the complex health system. And this is also included in that 2019 structural measure for the management of hypertension. One of the structural measures under implementation of a system of care for patients with high blood pressure is using team-based care. So we've talked about the fact that we've got to think about community clinical linkages, we've got to address social determinants of health. Now we're talking about the importance of team-based care in achieving equity for patients with blood pressure. So these are some of the goals, right? It's actually been shown that team-based care reduces clinician burnout because you have a whole team helping you to manage all other issues that you would normally think about or face. So these are the goals of team-based care, and it actually can be beneficial to the physician. So this is a study that was published in Annals of Medicine where they were looking at different strategies to control blood pressure, and they had different strategies. They were looking at team-based care, health coaching, prompts from the EMR, home BP monitoring, and a whole gamut of trainings. But you can see that with team-based care, with a non-physician, which is usually in this model, usually a pharmacist, they were able to achieve a net change in blood pressure. I talked about therapeutic inertia or clinical inertia that we usually see when we see a patient with high blood pressure. We're usually saying, giving different reasons or trying to convince ourselves why blood pressure is not controlled. So this is comparing a pharmacist-physician collaborative model with usual care. And look at the median days to first goal BP. In that pharmacist-physician collaborative model, it took them 36 days to get to the first goal BP. Whereas a patient going through usual care, usually primary care, it took them almost 260 days. And mean days between visits, so visits to the pharmacist who was helping to control blood pressure, 36 days for that pharmacist-physician model. And of course, you know how difficult it is to get into primary care, even cardiology, 102 days. So you can imagine the damage that was going on when blood pressure was uncontrolled. And the pharmacist-physician model tend to be more aggressive in titrating medications, in adding medications to get that blood pressure control. Of course, therapeutic inertia was more evident in the usual primary care group. So, show me the money, right? People are thinking about all these things sound good. Does it really have any financial or economic benefit? So in the Baba shop, they were able to show over $40,000 per quality adjusted life year gained. And even in the pharmacist medication therapy management clinic, close to $40,000 as well. And this is a group that we don't talk about the most community-based pharmacists, or like a pharmacist in one of the grocery stores. They actually can play a role, if properly employed, in controlling blood pressure. So finally, talking about telehealth, mobile health, and other digital strategies to manage high blood pressure. So we all know about self-measured blood pressure monitoring or out-of-office or home monitoring. I think that it should be combined with telemedicine. It's useful for diagnosing high blood pressure, treating high blood pressure, and even it could serve to help you assess how effective medical therapy is. But a word of caution here, the use of digital technology can further widen hypertension disparities if we don't address barriers to effective telemedicine. And we've all seen that in the COVID pandemic, especially with my practice at Grady. So we have to address issues such as digital literacy, broadband access, to make sure that that digital divide does not keep on expanding. It has been shown in multiple studies, time will not permit to go through all of them, that it is cost effective and clinically effective to use SMBP. But we have not really examined the health disparities impact of SMBP. We're still in this COVID pandemic. Bob and I were talking about that a couple of minutes ago, but we got to make sure that as we think about telemedicine, as we think about SMBP monitoring, we got to think about equitable access. We got to make sure that our patients have access to blood pressure medications. So, and they have access to blood pressure monitors, and not only to blood pressure monitors, but to validated blood pressure monitors. I know, thinking about your patient with that uncontrolled blood pressure, who tells you, oh, their blood pressure is normal at home, and you ask them what blood pressure monitor, and they have this risk blood pressure monitor, or they have a blood pressure monitor that is not validated, and you'll keep on wondering, oh, the blood pressure reading in the office is different than the blood pressure at home. We need to think as a group, we need to think as a society of not only making sure that there's equitable access to validated blood pressure monitorings. Of course, how do we measure blood pressure? That's also it factors in on how to achieve blood pressure control. The community health worker can play a good role here. We need to make sure that we teach our patients how to measure blood pressure correctly. This position statement, an international position statement, really highlights the telemedicine, not only for hypertension, but for cardiovascular disease, and how it includes a multidisciplinary team. We've got to think about the transmission. We've got to think about how do we achieve blood pressure control. The next paper talks about benefits and challenges. This paper actually came right out here of Emory. Dr. Patel is a resident, and he was mentored on this paper by Larry Spaulding, and they really highlight the benefits and challenges to using telehealth systems. So it offers the benefit of offering improved access, lower costs. You can see the patient in the natural environment. In the time of COVID, you didn't have to worry about social distances, and really patients liked it. But what the challenges we face? What was the reimbursement? At Grady now, most of my practice, less than 5% involves telemedicine, because there's a facility fee that Grady gets when patients come into the hospital. Perhaps we need to think about an equitable payment model for physicians who do telemedicine. You always worry about data security and privacy, and I already talked about disparities in access. And, there's some form of depersonalization that you experience with telehealth. There's no substitute for seeing a patient, examining them, being in the same room with them. And of course, we have to always think about adopting digital strategies. So this summarizes everything we've talked about. I hope you're thinking about that patient with uncontrolled hypertension, where really we spend 100% of our time in that 20% arena. But we need to start thinking outside the box. Your patient comes with uncontrolled hypertension. What are the things that we can do? Perhaps employing team-based care, using pharmacy, collaborative agreements, self-measured blood pressure monitoring with clinical support. So these are some examples of promising interventions to address hypertension disparities. All this will not be possible. We've got to think about the financing and the funding for delivering equitable health care. So putting all together, we got to perform accurate blood pressure measurement, identify and address social determinants of health. So screen and address. You have a multidisciplinary team that can help you. I didn't talk about the ASCVD risk and the pulled cord equation, but there's something to be said for making sure that whatever equations we have do not exacerbate disparities. Team-based care, digital health, all of this will lead us to that goal of achieving blood pressure control. So in conclusion, I hope that I have got you thinking about a different way to achieve blood pressure control. Think about social determinants of health. Race and ethnicity is just a social construct. It's not a cardiovascular risk factor. The real risk factor is racism and discrimination, and now they're incorporated into social determinants of health. We should routinely consider social determinants of health in clinical assessments and build on the populational health fundamentals to address social determinants of health. We've talked about community clinical linkages, an example, the barbershop trial. Look at best practices and really take care to the community through community outreach and provide culturally tailored approaches to address barriers to hypertension control. I've talked about team-based care. I've talked about SMBP in combination with telemedicine to improve hypertension control. I'm leaving you with a call to action. The surgeon's call to action saying that hypertension control is a national priority. We need to address broad arrays of risk factors as well as engage partners across all sectors. To achieve hypertension control and reduce inequities, we have to translate evidence-based recommendations into practice, especially at the populational level. In our paper, we say that we must move past admiring these unacceptable, long-standing disparities in hypertension. We talk about hypertension disparities all the time, but now is the time for us to move to equitable, practical strategies and solutions. We must ensure that the existing disparities we have are not worsened, but we make continual efforts to promote equitable healthcare access for all. We must incorporate team-based care, equitable access to telemedicine and SMBP in the management of patients with hypertension. And the Resolve to Save Lives just summarizes what the Surgeon General report says. Make hypertension control a national priority. Ensure that places where people live, learn, work, and play support hypertension prevention strategies and control. And everything we do has to be centered around the patient to optimize patient care for hypertension. Thank you.
Thanks for that fantastic talk. I'll start off with a question. We also have one in the chat, and other folks, please put your questions in the chat. Anybody in the room can have that question too. The first question is about PharmDs in Georgia. I mean, pharmacists and PharmDs the data show that extremely helpful, probably better than we are at caring for these patients and provide an important role. But what about the prescribing limitations that PharmDs face across, in different states, and particularly in Georgia?
Yeah, I think that's a very important question. We haven't, and that's part of things that need to be changed at the policy level. Even though we have this collaborative agreements between physicians and pharmacists, it's not well adopted. So I think the first step is that we have these collaborative agreements, but we got to think about prescriptive challenges that we face. So I think that is not something that we can fix at a healthcare system level, but it has to be a policy issue that we have to address.
Yeah, and in certain things, like the VA, for example, is sort of this isolated, separate state, and in that setting, of course, the PharmDs actually run the hypertension clinic.
Yes.
Do a great job. So there's a question from Larry. It's long, so I'm going to, Larry, my apologies, I'm going to paraphrase a little bit. You have two questions buried in there, including a plug for the Million Hearts program, which is great. But the second question he asked is one of the most effective strategies appears to be use of a single once a day single pill fixed dose combination. Can you talk about that a little bit?
Yes.
What your thoughts are?
I thought I was going to run out of time because I knew somebody was going to ask about that. So the poly pill, and how do we think about, is that a way to promote adherence to therapy? But when we think about the poly pill, I definitely believe, like when you think about the mechanism or the thought behind it, it's a way to increase, and in fact, we're doing some of it now. But when you think about combining 4 or more medications, you got to think about the stability of the pill. You got to think about even, is this an option that pharmaceutical industries will support? I think there are multiple factors to think about. There are a lot of clinical trials, especially in Canada, that has shown the effectiveness of the poly pill in controlling hypertension. So I think as we talk about hypertension control, I only covered maybe a part, but I think there are different issues. You've got to talk about poly pill, you've got to talk about adherence to therapy, you've got to talk about salt reduction, So I think that on a global population level, the World Health Organization has done a lot of work with their shake the salt habit. And recently, in the last couple of weeks, the CDC put out also sodium reduction in the community. So all this are at a population level trying to reduce and achieve hypertension control. But I think you raise a good point, Larry. Of course, the Million Heart program has the hypertension control champion. They have the hypertension control package as well. All these agencies working together really to achieve the national goal of hypertension.
So the other question Larry has buried in there is, so what do we have to do to make healthcare systems make blood pressure control a priority? Because it's clearly not.
Yes, it's not. I think that, that's a very good question. I think that if we give him the same weight that we give other chronic conditions, right? So if you think about cancer, if you think about even close to home, if you think about cardiovascular disease, if you think about MI, we underestimate the gravity of high blood pressure, of hypertension, whereas it's the precursor to all cardiovascular disease. I think that we have to think outside the box and engage partners, show value to employers. And that's part of what we do with the Hypertension Control Roundtable. We're bringing employers, we're bringing insurers, we're bringing people who normally are not at the table, because we've done the same thing for decades about controlling hypertension. We have the clinicians in the room, we have community organizations in the room, but now I think it's time for us to reach out to employers, to insurer companies, to even at a health policy level. If we make if everybody's aware that controlling hypertension, and we got to keep on talking about this data. I think it's abysmal that as a nation, only 1 in 5 people have their blood pressure control. We've talked about engaging people in the community. So if you look where do people get their health information? On TV, right? You see, we talked about in one of our brainstorming sessions where one ad that really made an impression on patients was an ad where you saw someone smoking and you saw the lungs black. What if, on TV, it's all there all the time. High blood pressure is the silent killer, and the effects of blood pressure, people don't really relate blood pressure to the target organ complications. So it becomes real for a patient when you tell them that if your blood pressure is not controlled, you are going to end up on dialysis, or you're going to have a heart attack or a stroke. One thing I tell my patients is that you don't want to have a stroke, because what if you have a stroke and you have a disability? You can't even change your remote control, So we have to make it real for the patients. We have to engage all sectors, and we have to address it at the policy level.
Thanks so much for that great talk. I've always been interested in how folks get to their physicians. And I know at Grady that we've spread out a bit. For example, I know we have a clinic out on Buford Highway. I know we have a clinic in Kirkwood.
Yes.
But I'm not sure what we're teaching our house officers. When they say, we'll see you back in the clinic in 3 weeks to follow up on your blood pressure, and then when they come in a taxi, then access is a real issue. So I think that what we've done by moving some of these clinics out and improving access, I think we got to do more of that, and which gets to the point that you made about having the communities involved in helping us treat blood pressure. Yeah. Yes, we built a lot of fancy neuro ICUs, dialysis clinics spread all around, and rescuing MIs, the 3 major complications of hypertension, and but we need to do more with access, and we need to think about it. Yeah. One of my little pet peeves is that we're teaching our house officers, and that happens here all the time, to discharge patients with like lisinopril, 10 milligrams for 30 days with no refills. I fight that really hard, but every month I see that. And for heaven's sakes, give your patients 90 days on medications like lisinopril. Yeah. Make sure they have plenty of it, for heaven's sakes. And but I have not made, somebody's teaching them that. And we even watch them do it here, because when they come here, we see how they function. Then they have to call to get it. Yeah. It's one thing to have access to medications at our local pharmacy, at our outreach clinics, or at Grady, whatever. But when you walk into CVS, it becomes a different ballgame.
Yes.
And when we prescribe medications for hypertension, we need to keep them simple. That's the polypill bothers me a bit. I mean, if they have an allergic reaction, which one did they react to? You have no way of knowing.
Yeah.
But keep the medication simple, like lisinopril, like hydrochlorothiazide, like maybe a calcium channel blocker. It takes a lot of time also to explain these medications to patients and make sure they have access to come back to get them.
Yes.
They need blood pressure cuffs too.
Yes.
You need some feedback on that too. But they can't just walk into CVS and pay $75 for an Omron blood pressure cuff. A lot of them can't.
Right.
And then furthermore, when they get it, they don't know how to use it. But yeah, we have to do that in our outreach clinics.
Yeah.
And other personnel like pharmacists, PharmDs that are coupled with a primary care person of one kind or the other. So there's a lot of work to be done with that. I think we have made progress in the last 30 or 40 years.
Yep. Mm-hmm.
And we need to make some more progress.
Yeah.
The big cities is tough. When you talk with them about it in smaller communities, they can't get into their primary care doctor. So you have to think about access a whole lot. I'm not sure we do that enough. We've got to continue to do more.
Yeah. Thank you for all those points. I just want to highlight, I didn't talk about all the social determinants of health, but in the heart failure program at Grady, one of the things that we do is to address that same issue, transportation access. So we've partnered with ride-share support such as Uber, Lyft. There's another local transportation company where patients who are admitted to the hospital with a diagnosis of heart failure and require transport assistance to come for their heart failure appointment, a dedicated community health worker actually arranges transportation for them to bring them to the hospital, to their clinic visits, and to return them back home. The challenges, of course, with the other satellite clinics, I practice in one of them, the one at ACNC is right at the train station, but the one in, used to be called Limburg on Beaufort Highway, there's no way to get there except you have a car. So I think that as we think about access to transport as part of social, determinants of health, I do know that in the residency program, they have a distinction along social medicine. There's a social medicine curriculum, and hopefully, as we talk about this more, our medical students, our trainees will have it imbibed in them that medical school really sometimes is all about that 20%, but we need to think outside the box and think about the 80% that really drives cardiovascular outcome. But your comments are well taken. Thanks.
Well, I think with that, we're going to go ahead and finish today, but thanks so much for a fantastic and very inspiring talk. Thank you.
Thank you.
The preceding program is copyrighted by Emory University.